Hi students, so today we will be talking about the important things that we have already discussed in the class and that is important for the upcoming exam. So when we talk about the pattern of the exam, so there are four different types of the questions that come in the exam, and this is we are talking about the radiology. One is to identify the investigation. When the examiner is giving identify the investigation, it is usually a normal image. It is usually a normal image. Then when the examiner has given an abnormal image, he wants you to either make the correct diagnosis or identify the radiological sign, or there are clinical scenario which has been given, and most of these are usually integrated questions. So if the clinical scenario has been given, the examiner asks you what is the most appropriate next step, or the examiner has given you the clinical scenario and the image and ask about the diagnosis and the management. So whenever there is an image based question, what we need to do is that first we need to identify the options. We see the four options, then we go to the question, and then we see at the image. Okay, so we have discussed all this in the class, that in the radiography the most important thing is to identify whether this radiographic density is at the normal location or at the abnormal location. So what do we see here? We see there is an abnormal black area, and we do not see any of these blood vessels. We do not see any of the blood vessels. So this is an lucent area. Black area is a lucent area, and this is devoid of the vascular marking. This indicates that there is a pneumothorax. This indicates there is a pneumothorax, and it is a left-sided pneumothorax. Another patient, this is a patient with pain abdomen. Patient has a sudden onset abdominal pain, and now a chest X-ray has been shown to you. What do we see? We see just below the right dome of diaphragm there is air, and this indicates bowel perforation or pneumoperitoneum. So this always indicates a pneumoperitoneum. So these are few of the abnormal areas of the black density or the air density. So when we talk about the bone density is seen in the bones or outside the bones, outside the normal anatomical location of the bones. We see it either within the parenchyma or in the lumen. And here it is there in the lumen. It is taking the shape of the dilated pelvic glacial system. So if it is taking the shape of a lumen, this is a calculus. This is a calculus. And what is a special type or the name that has been given to this calculus? It is a staghorn renal calculus. Staghorn renal calculus. Staghorn renal calculus. Or there could be bone density which is taking the shape of the organ. This is taking the shape of the organ. This is taking the shape of the parenchyma. This is calcification. This is calcification. This is a putty kidney. This is a putty kidney. So these are the abnormal locations of the air density and the bone density. In the air density, it can either be in the pleural cavity, it is pneumothorax, or this can be in the free air in the peritoneal cavity, that is the pneumoperitoneum. Then the bone density at the abnormal location, it is calculus or calcification. Calculus happens within the lumen and calcification happen within the solid tissue of the organ. Okay. Ultrasound uses the principle of the piezoelectricity, and there are different probes that we have. Ultrasound uses the principle of the piezoelectricity. It is based on the principle of piezoelectricity. It is based on the principle of the piezoelectricity. MRI is based on the principle of gyromagnetism. Wherever this Q has been written, that means some this has been asked in the recent past. This image has been asked in the recent past. So this is a transabdominal sonography of the pelvis. This is a transabdominal sonography of the pelvis. And if we use a high frequency probe within the cavity, that is called as the transvaginal sonography. And here we see there is a transducer. We can see there is the label of the transducer. This is an endoscopic ultrasound. This is endoscopic ultrasound. Endoscopic ultrasound is the investigation of choice. This is an investigation of choice for the local staging. For local staging of cancer esophagus. Local staging of cancer esophagus. This is a linear probe. Linear probes are used for evaluating the superficial structures. So this is an image of thyroid gland. This is an image of thyroid. This is an image of thyroid gland. Okay, and this has been done with the linear probe. This is with the use of the linear probe has been used. Okay. Then we also have different forms of the Doppler or different applications of the Doppler. When we see there is a blue and the red color, that means we are getting information about the direction of the flow. Direction of the flow. Then we have what is the peak velocity? What is the peak velocity of the flow? And then we have different patterns of the flow. So this is a pattern that is seen in the extremity arteries. This is called as the triphasic pattern. This is a triphasic pattern. This is a triphasic pattern seen with the extremity artery. This is seen with the extremity artery. This is seen with the extremity artery. What do we see? There is a spike and then there is a continuous flow in the diastole. There is a spike and then there is a continuous flow in the diastole. This is monophasic with pulsations. Monophasic flow with pulsation. Monophasic flow with pulsation is a feature of visceral arteries. Visceral artery, renal artery, umbilical artery, which requires continuous flow throughout the systole and the diastole. And then we have a flow that is without the pulsation. This is a monophasic flow. This is a monophasic flow without pulsation. Monophasic flow without pulsation. This is a feature seen with the veins, extremity veins. This is a feature seen with the extremity veins. Okay, so these are the different patterns of the flow that we see in the Doppler. In the Doppler, the examiner can give you an image of the Doppler study and ask you to identify what is the investigation, or he can ask you about the different patterns of the flow. We have the triphasic flow that is seen with the extremity artery. Then we have monophasic with pulsation seen with the visceral arteries. Then we have the monophasic without pulsation that is seen with the extremity veins. Okay. Coming on to the cross-sectional imaging, the CT and the MRI. How do we identify whether it is a CT scan or the MRI? We look at the cortical bone. Look at the cortical bone. If cortical bone is white, it is a CT scan. This is a CT scan. Okay. And if the cortical bone is dark, if the cortical bone is dark, it is an MRI. It is an MRI. Here also we see the cortical bone is dark. Here also we see the cortical bone is dark. But in MRI we have two sequences. One is a T1 weighted sequence. The other is a T2 weighted sequence. In the CT scan, we describe the areas with the terms of the density, hypodensity, isodensity, and hyperdensity. In the MRI, we use the term intensity. And how do we identify whether it is a T1 weighted or a T2 weighted MRI? We use a mnemonic, and that is called as the World War II. World War II. World War II. This is water is white on T2. Water is white on T2 weighted MRI. Water is white on T2 weighted MRI. Okay. In the nuclear scans, this is exactly opposite of the radiological scans. So in the radiological scan, if the area shows contrast uptake, that appears as white. Areas of contrast uptake in CT and MRI appears as white. Okay. Whereas in a nuclear scan, areas of uptake appear as black areas. In nuclear scans, areas of uptake appear dark. Areas of uptake appear dark. Okay, this is exactly opposite of the radiological scans. This is exactly opposite of the radiological scans. Okay, how do we identify which scan it is? We look at the areas where there is uptake. So we see the dark areas at the ends of the bone, at the ends of the bone. This is a symmetrical uptake. Symmetrical uptake at the ends of the bone. This is a normal bone scan. Normal bone scan. Here what do we see? We see areas of asymmetric uptake. Areas of asymmetric uptake in the vertebra. Asymmetric uptake on bone scan indicates osteoblastic metastasis. This indicates osteoblastic metastasis. Osteoblastic metastasis. This indicates osteoblastic metastasis. And it is also important to remember multiple myelomas, they are pure lytic lesions. They do not show uptake on the bone scan. Multiple myeloma appears as cold spot. Multiple myeloma appears as cold spot. Thyroid cancer appears as a cold nodule on a thyroid scan. Thyroid cancer also appears as a cold nodule. Sir, appears as a cold nodule. As cold nodule on, it appears as a cold nodule on the thyroid scan. And how do we do the thyroid imaging in India? We do it with the per technate. We do it with the per technate on the thyroid scan. That is the per technate scan. Per technate scan. Per technate scan. Okay. How do we identify the PET scan? So the FDG PET scan, FDG activity is present in the brain. Activity is present in the brain. So we look at the activity in the brain. If the activity is present in the brain, this is a PET scan. This is a PET scan. This is a white bone. This is a CT scan. This is a CT scan. If we combine both these two, CT plus PET scan, it becomes an fusion scan. That is an PET CT scan. Fusion scan, that is a PET CT scan. It is a PET CT scan. It is the investigation of choice for the staging of metastasis. For the staging of the metastasis. For the staging of the metastasis. Okay. In the radioanatomy, from the brain, this section is very, very important. Different structures have been asked at different points of the time. So we should be very, very clear about these structures. So what do we have? This is the area of the head of the caudate nucleus. This is the head of caudate nucleus. Head of caudate nucleus. Head of the caudate nucleus. And then we have this area, that is the lentiform nucleus. This is the lentiform nucleus. Lentiform nucleus. Lentiform nucleus has two parts, globus pallidus and the putamen. Globus pallidus and the putamen. Putamen is peripheral. Putamen, P is peripheral. Peripheral. This is the globus pallidus. This is the globus pallidus. Then between the lentiform nucleus and the caudate nucleus, we have a bow-shaped structure. We have a bow-shaped structure. And this structure is called as the internal capsule. Internal capsule. Then we have two paired structures over here, and this is the bilateral thalamus. This is the thalamus. This is the right thalamus. This side would be the left thalamus. We have internal capsule. We also have an external capsule. This is external to the lentiform nucleus. This is external capsule. External capsule is external to the lentiform nucleus. Okay, so these are few of the structures that we need to remember in this scan of the brain at the level of the lateral ventricles. Okay, then we also need to identify few of these structures. What is this? This is the optic nerve. Optic nerve. This is the fourth ventricle. Fourth ventricle. And just anterior to the fourth ventricle, what do we have? We have the part of the brainstem, that is the pons. Pons is anterior to the fourth ventricle, anterior to fourth ventricle, anterior to the fourth ventricle. And these are the cerebellar hemisphere. These are the cerebellum. This is the right cerebellar hemisphere. The other side would be the left cerebellar hemisphere. This is the temporal lobe. This is the right temporal lobe. Right temporal lobe. And this structure slightly above the level of the fourth ventricle, this is the level of the midbrain. This is the Mickey Mouse like appearance of the midbrain. Midbrain has the Mickey Mouse ear appearance. Mickey Mouse appearance. This is the level of the midbrain. This is the level of the midbrain. Now coming on to the neuroradiology part. Okay, so these are few of the images of the radio anatomy that we need to remember, and also the different imaging modalities that we use in the radiology. Okay, so whenever we have a patient with the head trauma, the first investigation that we are going to do is the NCCT. Investigation of choice is NCCT. First investigation is the NCCT. We want to rule out any intracranial bleed, and this hyperdense bleed, this is an hyperdense bleed, lentiform shape bleed. This is an acute EDH, acute extradural hematoma. Treatment is craniotomy, burr hole craniotomy. This is an acute extradural hematoma. It appears like a lens shaped. This is lens shaped. This is also called as an idli shaped. This is also called as an idli shaped. Usually it is associated with the skull fractures. Usually associated with skull fractures. Here what we see this is an bleed. This is a sickle cell of the bleed. This is a concavo-convex. This is semi-lunar shape. This is also appears like a banana. This is a banana shape of the bleed. This is an acute subdural hematoma. This is an acute subdural hematoma. Subdural hematomas can be acute, can be subacute, can be chronic in the presentation. It is due to the rupture of the bridging cortical veins. Here the extradural hematoma, it is usually due to the rupture of the arteries. It is an arterial bleed. Injury to the arteries. Most commonly it is a middle meningeal artery. Middle meningeal artery. This is usually due to the injury to the cortical veins. This is usually due to the injury to the cortical veins, not associated with the fractures, not associated with skull fractures. It is not associated with skull fractures. It is seen in the young patient, in the child abuse cases, or in the elderly patients. Or it is seen with the cases of the child abuse, battered baby syndrome. Okay. Patient with head injury and unconscious, plus it has a normal NCCT. It has a normal NCCT in about 80% cases. This is what? This is a diagnosis of the diffuse axonal injury, diffuse axonal injury. What happens in 20%? In 20% cases, we have small hemorrhages. 20% NCCT is abnormal. And what are these abnormalities? Small hemorrhages at the gray-white matter junction, in the brainstem and in the corpus callosum. Small hemorrhages. We have small hemorrhage, punctate hemorrhage. And where are these hemorrhage located? Where are these hemorrhage located? It is located either at the gray-white junction, gray-white matter junction, or it is located in the corpus callosum, or it is located in the brainstem. These are the classical sites of hemorrhage in a case of diffuse axonal injury. Most common cause for any intracranial bleed. Most common cause for any form of the intracranial bleed, it is trauma. It is trauma. Most common cause of the subarachnoid hemorrhage is also trauma. But what is the most common cause? Most common cause for spontaneous subarachnoid hemorrhage. Spontaneous means atraumatic, non-traumatic cause. Subarachnoid hemorrhage. This is rupture of the berry aneurysm. This is due to the rupture of berry aneurysms. There are no specific shape to the subarachnoid hemorrhage. So how do we identify? There is no shape of the SAH. Some call it the shape of the star, but that will happen only when there is a bleed in the basal cistern. So it is mainly blood in the CSF spaces. Wherever there should be normal CSF, there is blood. It can either be in the ventricles, it can be there in the cisterns, it can be there along the fissures and along the cerebral sulci. What do we see? There is a patient with severe headache. First investigation is an NCCT. First investigation is NCCT. NCCT shows the subarachnoid hemorrhage. If the NCCT shows acute subarachnoid hemorrhage, what is the next step? Acute SAH is the diagnosis. What are we going to do next? Next, we are going to do a CT angiography. To rule out aneurysms, If aneurysm is confirmed, then what we are going to do? We are going to do a catheter angiogram. And after doing a catheter angiogram, we will do the coiling of the aneurysm. Catheter angiogram followed by coiling, the coiling of the aneurysm, This is a normal catheter angiography image. Of the brain. Image of the brain, followed by coiling of the aneurysm. If the facility of coiling is not available, then we can also do the surgical clipping of the aneurysm. But for doing the surgical clipping, we need to cut open the skull and then go into the up to the level of the aneurysm, and that is quite a extensive surgery, followed by a clip. We can also do a clipping of the aneurysm, but this is less preferred. This is not a preferred management. This is less preferred treatment. Another pathology that is commonly seen and routinely asked, it is also a neuroradiological emergency, and that is the patient with suspected stroke. What is the first investigation? The first investigation is NCCT. First investigation is NCCT. It will either show hemorrhage present, or there is no hemorrhage. And if there is no hemorrhage, it is likely to be an ischemic stroke. Ischemic stroke will appear as a white area on the MRI. It appears as a white area on the MRI. Hemorrhagic stroke appears as a white area on the CT scan. White area on CT scan. And why it is important to differentiate between a hemorrhagic stroke and a ischemic stroke? Because in the hemorrhagic stroke, thrombolysis is contraindicated. Thrombolysis is contraindicated. And in the ischemic stroke, treatment of choice is thrombolysis. If IV thrombolysis less than 4.5 hours, if the presentation is less than 4.5 hours, and between the 4.5 to 24 hours, it is mechanical thrombectomy. 4.5 hours to 24 hours. 4.5 hours to 24 hours. What do? We do the mechanical thrombectomy. After 24 hours, the treatment is only supportive. So these two conditions, head trauma and stroke, they are very, very important, and we usually get a clinical integrated question from these two topics. Okay. Patient who has come with fever, convulsions and altered sensorium. We know that there is inflammation of the brain. There is inflammation of the brain parenchyma. And what is it called as? Inflammation of the brain parenchyma. It is called as encephalitis. And what are the causes, or what are the two more important ones which are asked in the exam? So in one, if there is involvement of the bilateral thalamus is getting involved. In the other, there is involvement of the bilateral frontotemporal lobes. Bilateral frontotemporal involvement. Temporal involvement is there. Bilateral frontotemporal involvement is there. This is herpes encephalitis. This is Japanese bee encephalitis. This happens in the endemic areas. Japanese bee encephalitis in the endemic areas, eastern UP, Bihar, endemic areas. Farmer working in the paddy fields, farmer working in paddy fields. Okay, and then there is involvement of the bilateral thalamus. Bilateral thalamus. This is Japanese B encephalitis. Coming on to the various ring enhancing lesions that we see in the brain. So again, there will be a history. If there is a history of sinusitis, history of ear infection, this is a brain abscess. This is a brain abscess. Brain abscess. Here we can see this is the single lesion. There is a single peripherally enhancing white lesion. Single ring lesion. Single ring lesion. Here what do we see? We see multiple ring lesions which are joining each other. Multiple ring lesions joining each other. This is conglomerated ring enhancing lesion. This is tuberculomas. Conglomerated ring enhancing lesions. Conglomerated ring enhancing lesions. This is tuberculomas. This is tuberculomas. This is a patient history of organ transplant is there. HIV patient, HIV positive patient, immunocompromised patient, and we see multiple ring lesions. This is, and then we see the multiple ring lesions. This is indicative of the toxoplasmosis. This is indicative of the toxoplasmosis. There is a ring lesion, small ring lesion, and there is a white dot. There is a cyst, and outside this cyst we have an enhancement. We have the enhancement, and there is a dot. This is a cyst with the scolex. This is a cyst with scolex. This is indicative of neurocysticercosis. This is indicative of the neurocysticercosis. Okay. Lytic lesions of the skull are also very important. Whenever we have multiple lytic lesions, always see the age of the patient. Age less than 30, age more than 30 years. If the age is more than 30 years, it is multiple myeloma. This is multiple myeloma. If the age is less than 30 years, it is eosinophilic granuloma or Langerhans histiocytosis. It is eosinophilic granuloma, or it is Langerhans histiocytosis. Langerhans cell histiocytosis. Langerhans cells histiocytosis. Okay. Then there could be lesions which are very, very, very small. These are very small, like a black and white dots. This is called as the pepper pot skull. This is called as the pepper pot skull. Pepper pot skull is a feature of hyperparathyroidism. It is a feature of hyperparathyroidism. 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 There could be large white areas. There could be larger white lesions. These are called as the cotton wool skull. This is called as the cotton wool skull. Cotton wool skull is a feature of Paget's disease. Is a feature of Paget's disease. Is a feature of Paget's disease. NCCT brain, and what do we see? We see there is a collection of the air. There is a collection of the air. This is an air collection. This is an air collection. This is called as tension pneumocephalus. Tension pneumocephalus. Tension pneumocephalus is a feature or a sign that is seen with the called as the Mount Fuji sign. This is a Mount Fuji sign. Tension pneumocephalus usually after the intracranial operations or with the head trauma, and there has been a fracture of the skull bone. There is a collection of the air under tension. This is tension pneumocephalus, and the sign is called as the Mount Fuji sign. What do we have? We see there is a herniation of the cerebellar tonsil. Chota bhai. This is a Chiari malformation. Chiari 1 malformation. This is a Chiari 1 malformation. And when this is combined with a back swelling, there is a back swelling, plus there is a back swelling. This makes the Chiari 2 malformation. This makes the Chiari 2 malformation. This is Arnold Chiari malformation. Arnold Chiari malformation. Tonsillar herniation plus a back swelling. This is Arnold Chiari malformation. Arnold Chiari malformation. Arnold Chiari malformation. What do we see over here? We see the posterior fossa is enlarged. The posterior fossa is enlarged and it is filled with the cyst. Large posterior fossa filled with the cyst. Large posterior fossa. This is a Dandy Walker malformation. Cyst. This is Dandy Walker. This is a Dandy Walker malformation. This is a Dandy Walker malformation. This is a Dandy Walker malformation. Now coming on to the acute condition that we usually see in the chest. Hypertensive patient with an acute chest pain. The first differential diagnosis is myocardial infarction. And we have done the ECG and the cardiac enzymes are normal. The ECG is also normal. If the ECG is normal, the cardiac enzymes are normal. And then we have done an CT angiography. Okay, we have done a echocardiography. Echocardiography will suspect a diagnosis of the aortic dissection. And then how is it confirmed? It is confirmed with the CT aortography. Okay, so the first investigation, so the diagnosis is aortic dissection. The first diagnosis is aortic dissection. The first investigation for the diagnosis of aortic dissection, the first investigation will be the echocardiography, transthoracic echocardiography. The investigation of choice in the unstable patient will again be the transthoracic echocardiography, but for the stable patient it will be a CT aortography, CT angiography. And in the CT angiography, what do we get? We see the double lumen aorta. What do we see? We see double lumen aorta. we see two lumens, double lumen aorta. This is aortic dissection. Here also what do we see? We see there is a double lumen aorta, and classically there are two lumens, the true lumen and the false lumen. In the false lumen, what do we see? We see a sign that is called as the cobweb sign. Cobweb sign. Cobweb sign is a feature of false lumen. It is a feature of false lumen. It is a feature of false lumen. Hypertensive patient with a radiofemoral delayed pulse. And what do we see in this chest X-ray? We see there is an hump on the aorta, isn't it? Hump on the aortic arch. This is an inverted 3 appearance. This is an inverted 3 appearance. And with this, what do we get? Additionally, we are getting the notching along the inferior border of the ribs, plus inferior rib notching. Inferior rib notching. The diagnosis is coarctation of aorta. Diagnosis is coarctation of aorta. Coarctation of aorta. The diagnosis is coarctation of the aorta. Okay. Post-surgical patient, and on the ambulation there is a sudden onset breathlessness. Sudden onset breathlessness. Screening test would be the D-dimer. Screening test would be D-dimer test. Investigation of choice will be CT pulmonary angiography. Investigation of choice will be CT pulmonary angiography. And what do we see? We see there is a filling defect in the pulmonary arteries. There is a filling defect in the pulmonary arteries. This is a pulmonary angiogram. And this is a normal aortogram. Normal CT aortogram. Don't confuse this with the abnormal pulmonary artery. This is the non-contrast filled normal pulmonary arteries. This is CT aortogram. So what is the diagnosis? The diagnosis is pulmonary thromboembolism. Pulmonary thromboembolism. Pulmonary thromboembolism. Rib counting is another thing that is very important, and we have already discussed it in the class. So what we have part of rib not reaching up to the midline, not reaching up to midline. This is the anterior end of the rib. This is the anterior end of rib. Because the anterior end of the rib is connected to the sternum through the costal cartilage, and costal cartilage is not well seen. Then there is a part of rib reaching up to midline. And this is the posterior end of the rib, reaching up to the midline. This is the posterior end of the rib. This is the posterior end of rib. Okay, because it is directly connected to the vertebra, directly linked to the vertebra, and this is linked to the anterior end of the rib through the costal cartilage, and costal cartilage is not well seen on the X-ray. So how do we count the ribs? So we count the ribs from the anterior end of the first rib, and then we go back to the posterior end of the first rib. Posterior end of first rib. The first rib overlaps the medial 1/3 of the clavicle. first rib overlaps the medial end of clavicle. First rib overlaps the medial end of the clavicle. First rib overlaps the medial end of the clavicle. So this is the anterior end of the first rib. From the anterior end of the first rib, we go posteriorly. This is the first rib posterior. This is first rib anterior. Then we again come back to the anterior end of the second rib. Anterior end of the second rib, we go to the posterior end of the second rib. And then we again go back over here. This is the second rib, posterior end. Then we again come back to the anterior of the third rib, and then we go to the posterior of the third rib. So this is the first rib, this is the second rib, this is the third rib. So we can see that the anterior ends are widely spaced. We can easily identify the anterior end of the first, second, third rib, whereas the posterior ends are closely approximated. Once we have counted the first three ribs, we can easily count. This is the posterior end or anterior end of the fourth rib. This is the anterior end of the fourth rib. This is the anterior end of the fifth rib. Over here also, this is the fourth rib posterior, this is the fifth rib, this is the sixth rib, this is the seventh, this is the eighth, this is the ninth. So as we go down, they become more spaced out and we can count the ribs easily. So the main challenge is to correctly count the first three ribs. Correctly count the first three ribs from the anterior end of first rib to the posterior end of the first rib. Then again from the anterior end of second rib to the posterior end of the second rib. Then again from the anterior end of third rib to the posterior end of the third rib. And how do we identify whether it is an anterior end or posterior end? Anterior end will not reach up to the midline. The posterior end will reach up to the midline. We have a middle-aged female with a chronic cough and breathlessness, and there is an increased ACE levels. Angiotensin converting enzyme levels are increased. Chest X-ray has been done. What is the diagnosis? We can see that bilateral hilar lymphadenopathy is there. There is a bilateral hilar lymph node enlargement. Bilateral hilar lymph node enlargement is there. Lymphadenopathy is there. Pathy is there, and this is indicative of the sarcoidosis. This is indicative of the sarcoidosis. Can we get bilateral hilar lymphadenopathy in tuberculosis? Yes, it is also present in, it is also seen in TB. But the history will be different. The history will be different. Then we have a patient with a history of occupational exposure, and then there is breathlessness. Chronic breathlessness is there, and chest X-ray has been done. What do we see? We again see there are lymph nodes, but these lymph nodes have white margins. These have white margins. These are called as lymph nodes with eggshell calcification. These are lymph nodes with eggshell calcification. Lymph nodes with eggshell calcification. Lymph nodes with eggshell calcification, and this is seen classically with the silicosis. This is, what is the diagnosis? The diagnosis is silicosis. The diagnosis is silicosis. Post road traffic accident, the patient is having sudden onset breathlessness. Patient is having sudden onset breathlessness. Okay, what do we see? We see that the mediastinum is shifted towards the other side and the diaphragm is depressed. So contralateral mediastinal shift, and there is depressed diaphragm. There is a depressed diaphragm. All this indicates that the air in the pleural cavity is under tension. This is a diagnosis of the tension pneumothorax. This is a diagnosis of tension pneumothorax. This is a diagnosis of the tension pneumothorax. And what is the emergency treatment? Emergency treatment is wide bore needle thoracostomy. Wide bore needle thoracostomy. Wide bore needle thoracostomy. And in the children, it is done in the mid-clavicular line. In the children, in the mid-clavicular line, in the second intercostal space. Second intercostal space. In the adults, it is done in mid-axillary line, fifth intercostal space. Fifth intercostal space. But we have to remove the entire air. We need to do a definitive treatment, that is the intercostal tube drainage. Definitive treatment is intercostal tube drainage. Treatment is intercostal tube drainage. Intercostal tube drainage. We can also do bedside ultrasound for the diagnosis of the pneumothorax, and that is called as an M mode ultrasound. We can use an M mode ultrasound. And what is the full form of the POCUS? POCUS is the point of care ultrasound. Point of care ultrasound. Point of care ultrasound. Point of care ultrasound is POCUS. Is doing ultrasound where the patient is receiving treatment. Doing ultrasound where patient is receiving treatment. This will reduce the time for the patient. When the patient cannot come to the ultrasound room, the patient is in the ICU, the patient is in the intraoperative time, okay, patient is in the emergency unstable patient, what we can do? We can do a point of care ultrasound. And what is the ultrasound that we are using for the diagnosis of the pneumothorax? We are using an M mode ultrasound. We want to look whether we can identify the normal movement of the air, in the lungs. If we can identify normal air movement in the lung, identified, then what is this sign called as? This is called as the granular sign. This is called as the seashore sign. This is called as the seashore sign. It is also called as the granular sign. And this is indicative of the normal lung. This means there is normal lung, there is no pneumothorax. There is no pneumothorax. There is no pneumothorax. Whereas, if we cannot identify the normal lung movement, it also appears like the pleura. So, this is called as the stratosphere sign. Normal lung movement not appreciated. It is there, but it cannot be appreciated because now there is air in the pleural cavity that is not allowing the ultrasound beam to pass through it. Normal lung movement not appreciated. And we get two signs. One is called as the barcode sign. The other is called as the stratosphere sign. Stratosphere sign. This is indicative of the presence of the pneumothorax. Pneumothorax present. And what do we see here? We see multiple air-filled lucencies in the in the thorax. This is nothing but the bowel which has moved into the lung because there is the defect in the diaphragm. The diagnosis is the, what is the diagnosis? The diagnosis is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. The diagnosis is congenital diaphragmatic hernia. The next thing that we need to do is to decompress the stomach. To decompress the stomach, we use the nasogastric tube. Nasogastric tube to decompress the stomach. Bag and mask ventilation is contraindicated in such patients. What is contraindicated? Bag and mask ventilation. Bag and mask ventilation is contraindicated, and the most important prognostic factor in the congenital diaphragmatic hernia is the degree of the pulmonary hypoplasia. Degree of the pulmonary hypoplasia. Degree of pulmonary hypoplasia. 3-year-old child which has been left unattended and now presents with sudden onset respiratory distress. Okay, so these are the two different situations. In one, what is happening is that there is the bronchus, and the bronchus is completely obstructed by the foreign body. Complete obstruction. There is a complete obstruction. When there is a complete obstruction, it will lead to what? It will lead? It will lead to the, if there is a complete obstruction, there will be an collapse. Okay, so this is how it will appear. This is how it will appear. There is a collapse of the lung. This is a complete obstruction, complete airway obstruction by the foreign body. Complete airway obstruction by the foreign body. It will lead to the collapse of the lung. It will lead to the collapse of the lung. In the other situation, what is happening is that there is an incomplete obstruction. There is an incomplete obstruction. So what is happening? There is an foreign body, but it is acting like a ball valve. Incomplete obstruction. Incomplete obstruction. Allows air entry, but no exit because of the ball valve mechanism. There is a ball valve mechanism, and this is how it appears. It appears like the unilateral hyperlucency. Appears as the unilateral hyperlucency. Appears as unilateral hyperlucency. Both are indicative of the bronchial foreign body. Foreign body in the aspirated foreign body in the bronchus. Appears as unilateral hyperlucency. So it can present as either the collapse when there is a complete obstruction of the bronchus by the foreign body. Most of the time, the most common is the organic material, that is the peanut. Okay, and or there can be an incomplete obstruction. If there is an incomplete obstruction, it obstructs like a ball valve mechanism. So it will allow the air entry, but it will not allow the air to move out. So it will appear as there is more and more of the air that is getting trapped in the lung. It appears as a hyperlucent, unilateral hyperlucency. choking episodes, and we have done an X-ray. And what do we see? We see there are double line. There is a double ring appearance. If there is a double ring appearance, this is indicative of the button battery. This is indicative of the button battery. And what do we have to do? We have to do an emergency endoscopic removal, because this is made up of alkali. It can cause esophageal perforation. Emergency endoscopic removal. Scopic removal. Or there can be a coin. There can just be a coin. How do we identify that this is an esophageal foreign body? Full face of the coin is seen on the frontal X-ray, on the AP radiograph, on the frontal X-ray, not on the lateral X-ray. So that means that the foreign body is in the food pipe. The foreign body is in the food pipe. That is the 3F, full face on the frontal radiograph. That means that this foreign body is in the food pipe. Okay. If there is a coin, we do observation. Observation with the serial radiograph. Observation with serial radiograph. Observation with serial radiograph is done. Okay. If there is an opaque hemithorax, there is an image of the opaque hemithorax, we have to be very sure that whether there is a pull or a push on the mediastinum. So what do we see here? We see there is the trachea and it has been pulled by the opacity. Pulled by the opacity. Opacity, this is collapse. This is collapse. And if there is a push, on the trachea and the mediastinum, and we see the CP angle over here, the CP angle is blunted over here. This is a massive pleural effusion. This is a case of a massive pleural effusion. Massive pleural effusion. And in the consolidation, what happens? In the consolidation, there is no change of the volume. In the consolidation, there is no change of the volume. There is only replacement of the air by something else, and we get the air bronchogram. So consolidation is the replacement of the air. Consolidation, there is no volume change. And how do we diagnose consolidation? We diagnose it with the help of a sign that is called as the air bronchogram sign. Air bronchogram. We can see the air in the bronchus. Air bronchogram sign. Air bronchogram sign is present. So something like this, all of the following are causes of the abnormality that is seen in this chest X-ray except. So first of all, what do we need to do? We need to see the options. Pneumonectomy, there is decrease in the volume or increase in the volume? There is a decrease in the volume. What happens in the lung collapse? Again, there is a decrease in the volume. What happens in the diaphragmatic hernia? The diaphragm defect is there and the bowel loop will come in the thorax. There will be an increase in the volume. There will be an increase in the volume. What happens in the pulmonary aplasia or the hypoplasia? There will be an decrease in the volume. So what do we see? We see there is a pull on the mediastinum. There is a pull on the trachea. There is a pull on the mediastinum. The trachea has been pulled towards the side of the opacity. So that means there is a collapse. There is a volume loss. That means that there is a volume loss. There is a decreased thoracic volume. So which of the following is not a cause for the decreased thoracic volume? So the answer would be the diaphragmatic hernia. So first we need to see the options and then go to the image. Fever, cough and breathlessness, it could either be a consolidation, but what we are seeing here, we are seeing ground glass opacities. We are seeing the ground glass opacity in the bilateral lower lobes. Bilateral, peripheral, ground glass opacities. Ground glass opacities. What does this indicate? This indicates COVID pneumonia. This indicates the COVID pneumonia. COVID pneumonia. Again, in collapse, in the lobar collapse, what is going to happen? In the right upper lobe collapse, there will be a decrease in the volume. Decrease in the volume, and there is the bowing of the horizontal fissure. Bowing of the horizontal fissure. But here what is happening? There is a bowing in one part and then there is a bulge in the other part. This is because there is a tumor that is sitting over here. There is a tumor over here. This sign has been called as the reverse S sign or it is called as the golden S sign. Reverse S sign or golden S sign is a feature of the right upper lobe collapse due to bronchogenic cancer or lung cancer. It is right upper lobe collapse due to lung cancer. Due to lung cancer. This collapse is usually due to a benign cause. This is a benign collapse. Benign cause of right upper lobe collapse. Benign cause of the right upper lobe collapse. We know that we do not see any of these straight lines in the chest. If we see one, that indicates there is an air fluid level. This is a physiological air fluid level that is seen in the fundus, that is seen in the stomach. Air fluid level in the pleural cavity. What do we see here? There is an air fluid level in the pleural cavity, and there is collection of the air. The CP angle is normal, the CP angle is blunted. That means there is air and fluid in the pleural cavity. This is indicative of left-sided hydropneumothorax. Hydropneumothorax. Here the CP angles are normal. We see an air fluid level in the lung. Air fluid level in the lung is indicative of lung abscess. Air fluid level in the lung is indicative of lung abscess. What do we see here? There is a cavity, and in this cavity there is something which has grown and only a crescent of air is remaining. There is only a crescent of air. Air crescent sign is a feature of aspergilloma. It is a feature of mycetoma, fungal ball. It is a sign of fungal ball or mycetoma. And then here we have a wavy contour to the air fluid level. Wavy air fluid level, this is indicative of the hydatid cyst. This is indicative of the hydatid cyst. What do we see here? Patient with an osteogenic sarcoma, pre-procedure, pre-surgery, the chest X-ray has been done and it shows large, well-defined masses. This is cannonball metastasis. This is cannonball metastasis. Cannonball metastasis. Young boy with fever and weight loss. We see multiple small nodules. This is the chest X-ray and this is the HRCT, which is the investigation of choice. And what is the diagnosis? The diagnosis is miliary TB. The diagnosis is miliary tuberculosis. Okay. The HRCT is the investigation of choice for the evaluation of the miliary nodules. Pain, abdomen, plus chest X-ray has been done, what do we rule out? We always and always rule out pneumoperitoneum. Always rule out bowel perforation. Bowel perforation. Okay. Patient of ankylosing spondylitis with acute onset pain abdomen. Acute onset pain abdomen. And this is the chest X-ray that has been done. What are we going to do? Are we going to stop the painkillers? What is the diagnosis? So again, chest X-ray has been done in a patient with a pain abdomen. There is air under the right dome of diaphragm. Because of the chronic intake of the analgesics, there is a bowel perforation. There is a bowel perforation, gastric perforation. Patient. So what do we do for the pneumoperitoneum? Pneumoperitoneum, we do the stabilization of the patient, and for the stabilization we will do the IV fluids, stabilize plus exploratory laparotomy to identify the site of the dent, and then we close the area of the bowel perforation. Then we do the exploratory laparotomy for the repair of the bowel wall. Okay, so the correct answer would be IV fluids to stabilize the patient. The minimal amount of the fluid that can be detected on the chest X-ray is the 150 ml. Minimum amount of fluid is 150 ml. This is pleural effusion, isn't it? This is pleural effusion. Most sensitive radiograph is the lateral decubitus. Ipsilateral lateral decubitus is the most sensitive chest X-ray. Most sensitive chest X-ray for pleural effusion. For pleural, most sensitive chest X-ray for pleural effusion. And what do we see here? We see there is an air fluid level. This is hydropneumothorax. This is hydropneumothorax. Hydropneumothorax. Okay. Chest X-ray has been done 24 hours after the diagnosis of the pancreatitis. Okay, diagnosis of acute pancreatitis. What do we see? We see an ill-defined perihilar opacity. Ill-defined bilateral perihilar opacity. This is cardiogenic pulmonary edema because of the ARDS, perihilar opacities. This is cardiogenic pulmonary edema, and this sign has been called as the bat wing appearance. This is called as the bat wing appearance. This is called as the bat wing appearance. What do we see here? We see that the airway is dilated. The airway is dilated and thickened. This is indicative of bronchiectasis. This is indicative of the bronchiectasis. Investigation of choice is HRCT chest. HRCT chest. And it is associated with post-tuberculosis, post-TB. It can also be seen with the cystic fibrosis, or it can be seen with the Carter-Jenner syndrome. With the Carter-Jenner syndrome. It can be seen with the Carter-Jenner syndrome. In the CT, what do we see? Normally the blood vessel is larger than the airway. Here what happens? The airway is larger than the larger than the than the blood vessel. This is called as the signet ring sign. This is called as the signet ring sign. Signet ring sign. Another sign that we get is called as the tram track appearance. Tram tract sign. We also get the tram tract sign. Tram track sign and the signet ring sign is a feature of bronchiectasis, but this is seen in the chest. Tram track sign in the spine is indicative of ankylosing spondylitis. It is indicative of the ankylosing spondylitis. We see areas of the calcification. We see areas of the calcification. This is a bronchial. This is a case of a pulmonary hamartoma. Pulmonary hamartoma. Popcorn calcification on a mammography. On mammography, it is indicative of the fibroadenoma. Fibroadenoma. Okay. So different areas, the same terminology will have association with the different disease process. Okay. Then we have a silhouette sign. We all have read about it, that if two structures are touching each other, then the touching border will not be seen. So what do we see? We have an opacity over here, and this we cannot see the heart border. We cannot see the heart border between the opacity and the heart. So this means that this opacity is touching the heart. Heart is an anterior structure, so this has to be opacity in the right middle lobe. Here we can see the heart border, we can see the opacity. That means this opacity is not touching the heart. This is posterior to the heart, because heart is an anterior structure. This is a right lower lobe opacity. We need to understand that heart is an anterior structure, middle lobe and lingular anterior structure in the chest, and lower lobes are posterior structures. Lower lobe are placed posteriorly. What do we see here? Gross dilatation of the heart. The pulmonary vasculature is normal. This is called as the money bag appearance. This is called as the money bag appearance. This is a feature of pericardial effusion. This is a feature of pericardial effusion. Let's suppose similar chest radiograph, and the history is that there is a road traffic accident, hypotension is present, there are engorged neck veins. Then what is the diagnosis? The diagnosis is cardiac. Then the diagnosis is cardiac tamponade. And what is the treatment? The treatment is emergency ultrasound guided pericardiocentesis. Emergency pericardiocentesis. So just on the basis of the clinical features, the diagnosis will change. Pericardiocentesis. Emergency pericardiocentesis, that is life-saving. Also, the devices are commonly asked, and for all these devices, what do? We do the radiography. And what is this? This is the pacemaker device. We see these are the leads of the pacemaker. These are the leads of the pacemaker. And what is it? The second image. Here we see there are thickening in the leads. If there is a thickening in the leads, focal thickening in the leads. This is ICD device. This is an intracardiac defibrillator. This is an intracardiac defibrillator device. Intracardiac defibrillator device. How did you identify that which is the prosthetic valve? So we draw a line from the right cardiophrenic angle to the left hilar. Valve above is the aortic valve. Valve above is the aortic valve. So this is the aortic valve. Valve above is the aortic valve. Valve below is the mitral valve. Valve below is the mitral valve. So we can zoom this and we can see this will be the mitral valve. This is the mitral valve. This will be the aortic valve. Aortic valve. This will be the aortic valve. Congenital heart disease, you must have also read in the pediatrics, two of the conditions that are commonly confused. One is the tetralogy of Fallot, the other is the transposition of the great vessels. So the tetralogy of Fallot and the transposition of the great vessels. Tetralogy of Fallot usually present at the first birthday. Transposition of the great vessels will present at the first day of life. First day of life. Both of them will have a right ventricular dilatation, and that is why they have an upturned apex. In tetralogy of Fallot, because of the pulmonary stenosis, there is a decreased pulmonary blood flow. There is a pulmonary oligemia. There is a pulmonary oligemia. In the transposition of the great vessels, there is increased blood flow. The blood flow which was meant for the entire body is now coming to the lungs. There is increased pulmonary blood flow, that is called as the pulmonary plethora. Pulmonary plethora. Can we see these areas? These are all blood vessels. This is pulmonary plethora. Here we see this area is appearing dark, and this is because the pulmonary blood flow is reduced, so the area is appearing more dark than the rest of the, or compared to the second X-ray. Okay, so this is the tetralogy of Fallot, and this is the transposition of the great vessels. Just don't think about the boot-shaped heart. Because of the right ventricular dilatation, it may appear like a boot shape. The heart in the transposition of the great vessel may also appear like a boot-shaped. Okay, but it is, boot shape is defined for the tetralogy of Fallot. There are other ways in which we can differentiate between the two. Tetralogy of Fallot presents at the first birthday, 6 to 9 months, and it has pulmonary oligemia, that is decreased pulmonary blood flow. And why is it there is a decrease in the pulmonary blood flow? Because of the pulmonary stenosis. Pulmonary plethora, there is increased pulmonary blood flow. There is an increased pulmonary blood flow. Examiners have asked about the investigation. They have asked about the abnormalities. So the investigation is the mammography. Mammography, isn't it? And this is a popcorn calcification. This is a benign fibroadenoma. Popcorn calcification. This is a fibroadenoma. This is a fibroadenoma. And what do we see? We see there is a spiculated mass, ill-defined spiculated mass. Ill-defined spiculated mass. This is a cancer breast. This is a cancer breast. Okay, cancer breast. We need to remember, in pregnancy and lactation, investigation of choice is ultrasound. For breast implant and for differentiating the recurrent tumor from fibrosis, we do the MRI. Okay. Coming on to the patient with dysphagia, barium swallow of different patients, and what do we see? We see there is a short segment narrowing. This is a bird beak appearance. This is called as the bird beak appearance. This is seen with the achalasia cardia. This is seen with the achalasia cardia. There is a long segment narrowing. There is a long segment narrowing. This is called as the rat tail appearance. Rat tail appearance is a feature of cancer esophagus. Cancer esophagus. What do we see here? Alternate areas of dilatation and narrowing. Alternate areas of dilatation and narrowing. This is corkscrew esophagus. This is a corkscrew esophagus seen with the diffuse esophageal spasm. Diffuse esophageal spasm. Esophageal spasm. Single bubble. This is hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Here how many bubbles are there? 2 bubbles are there. Double bubble, it is a feature of duodenal atresia. Triple bubble, the third bubble will be below the first bubble. In triple bubble, third bubble is below first. Third bubble is below the first bubble. This is jejunal atresia. Jejunal atresia. This is the coffee bean sign. This is the coffee bean sign. Coffee bean sign is a feature of sigmoid volvulus. Is sigmoid volvulus. Sigmoid volvulus. Okay. Just see this question. How many bubbles are there? 1 and 2. So it is a double bubble. So all of the following are the causes of this appearance except. Even if we do not know about other options, we'll just try and figure out what is the abnormality. Okay. So we know that, try to find out something which we know about, and we know that the hypertrophic pyloric stenosis has a single bubble. It has a 1 bubble. So the correct answer would be the hypertrophic pyloric stenosis, 1 bubble. Non-bilious vomiting, young infant, male child, 4 to 6 weeks. And what is the investigation of choice for the hypertrophic pyloric stenosis? For hypertrophic pyloric stenosis, it is ultrasound. This is the ultrasound. Rest of them, they also cause the duodenal obstruction, and that is the reason why they can present with the double bubble appearance. So in the MCQ, it is not necessary that we know about all the options. Okay, so we should try and identify which option do I know from all these 4, and then we try to correlate with the other options. Okay. What do we see here? There are complete folds that we see over here. This is a small bowel obstruction. Small intestine obstruction. And what do we see over here? Again, this is a sigmoid volvulus. This is a sigmoid volvulus, large bowel obstruction, sigmoid volvulus. This is a sigmoid volvulus, coffee bean appearance. Child with pain abdomen and barium enema has been done. What do we see over here? We see there is a claw sign. This is a claw sign. In the ultrasound image, what do we see? We see the bowel within the bowel appearance. Bowel within bowel, or the double bowel appearance. Bowel within bowel appearance. Bowel within the bowel appearance. And this is This is seen with the intussusception. This is seen with the intussusception. Less than 24 hours of presentation, we do the reduction, hydrostatic reduction or air enema. Air enema or hydrostatic reduction. Ultrasound guided hydrostatic reduction, or we can do the air enema. This is preferred over the hydrostatic reduction these days. Okay. These are the images of the barium enema, and what do we see? We see there are outpouchings of the barium. There is barium outpouching. Barium outpouching. This is colonic diverticulosis. This is sawtooth appearance. This is colonic diverticulosis. Diverticulosis. What do we see here? We see there are filling defects. Filling defects. And these filling defects are due to polyps. These are due to the polyps. Diverticulosis, there will be outpouching of the barium. In the polyps, there will be a filling defect. In these two investigations, what has been done is that the bowel has been highlighted. So we need to identify whether it is a CT scan or it is an MRI. Bowel is highlighted. Bowel is highlighted. And this is a CT scan. So it becomes a CT plus bowel. This is a CT enterography. Enterography. This is bowel plus MRI. This is an MR enterography. MR enterography. MR enterography. CT enterography is the investigation of choice for diagnosis of the inflammatory bowel disease. Diagnosis of inflammatory bowel disease. Bowel disease, that is IBD. Okay. MR enterography is the investigation of choice for follow-up of the IBD. IBD. Okay. This is MR enterography. And this is CT enterography. This is CT enterography. Okay. And what are we seeing in these images? These two are the ultrasound images of the hydatid cyst. This is the hydatid cyst. Hydatid cyst. Floating water lily sign is seen. And here what do we see? We see multiple cysts peripherally arranged in the liver. This is a CT again of the hydatid cyst. What is the other sign that we see? We see the water lily sign, isn't it? We see the water lily sign. Ultrasound of the right upper quadrant in a patient with abdominal pain. Investigation of choice for gallbladder pathology, GB pathology, is ultrasound. Okay. And what do we see? We see this is the thin-walled gallbladder. Thin-walled normal gallbladder wall, and this is the shadowing that we are seeing with the calculus. This is an cholelithiasis. This is just the cholelithiasis. And here what do we see? We see that the gallbladder wall is edematous and there is a calculus. There is a calculus. and there is the edematous, thickened edematous gallbladder wall. This is the wall of the gallbladder. This is entirely thickened. This is seen with the inflammation of the gallbladder. Inflammation of the gallbladder is cholecystitis. And why is this inflammation happening? Because of the gallstone. This is calculus cholecystitis. This is acute calculus cholecystitis. Acute calculus cholecystitis. This is an MRCP image. MRCP, it is the investigation of choice for CBD pathology. Investigation of choice for the CBD pathology. This is ERCP. This is the gold standard for biliary tract pathology. Gold standard. And how do we identify? We see the biliary tree. We see the biliary tree plus the endoscope. We see the biliary tree plus endoscope. This is an ERCP image. This is an MRCP image. Here what do we see? We see there is a tube. That is a T tube. This is a T tube cholangiogram. T tube cholangiogram. This is a T tube cholangiogram. Then the examiner is also fond of asking about the different types of the stent. So this is a double J stent. This is a DJ stent. DJ stent, it is used in the ureters. Here also we see a stent. This is a plastic CBD stent. Plastic CBD stent. And this is used for the plastic stents are used for benign strictures. Benign strictures. This is a mesh-like metallic stent. This is a mesh-like metallic CBD stent. Metallic CBD stent. Metallic CBD stent. Metallic CBD stent is used for the malignant stricture. Malignant stricture. It is used for the malignant stricture, and then we have the DJ stent that is used for the ureters. Okay. Patient coming with the flank pain, and what do we see? We see the entire kidney is calcified. This is a putty kidney. Putty or a cement kidney. Seen with the end stage renal tuberculosis. Seen with the end stage renal tuberculosis. End stage renal TB. End stage renal tuberculosis. In the genitourinary tract, the examiner is very fond of asking about the normal investigations. Okay, so this was also asked in the last exam. This is, we see the pelvic calyceal system, ureters, and we see the urinary bladder. PCS plus ureter plus urinary bladder. And this if we see against the background of the X-ray. With X-rays. This is intravenous pylography or intravenous urography, IVP or IV urography. If we see it with the CT scan, then this becomes the CT urography. CT urography. This becomes CT urography. What do we see over here? Again, there is a kidney and that is fused across the midline. There is a kidney which is fused across the midline. This is an horseshoe kidney. Horseshoe kidney. Here the kidneys are enlarged and they are filled with the cyst. Bilateral kidneys are enlarged and they are filled with the cyst. Bilateral enlarged kidney, enlarged cystic kidneys. This is autosomal dominant polycystic kidney disease. This is autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. Different IVU images, and what do we see? Again here, the inferior pole calyx is facing medially. This is the flower vase appearance. Flower vase appearance. This is seen with the horseshoe kidney. Horseshoe kidney. Here what is happening? The kidney from here, this side, has moved to the other side and it is fused with the upper pole kidney. This is called as the cross-fused ectopic kidney. This is called as the cross-fused ectopic kidney. Here what do we see? We see one kidney over here and we have two pelvic calyceal system over here. This is a duplicated pelvic calyceal system. Duplicated pelvic calyceal system. Here what do we see? We see that the pelvic calyceal system is drooping down. This is drooping down. This is called as the drooping lily sign. This is called as the drooping lily sign. It is also a sign of the duplicated pelvic calyceal system. Duplicated pelvic calyceal system, where one of the kidneys, which is in the upper pole, is not functioning and it is pressing on the lower kidney. It is pressing on the lower kidney. Duplicated pelvic calyceal system with a non-functioning upper pole pelvic calyceal system. With non-functioning dilated upper pelvic calyceal system. Upper pelvic calyceal system. Child with a recurrent UTI, and what do we see? The lower end of the ureter is dilated. This is called as the cobra head deformity. Cobra head or adder head deformity. This has also come in the previous exam, isn't it? Adder head deformity. This is seen with the ureterocele. This is seen with the ureterocele. This is seen with the ureterocele. There can be investigation of the lower urinary tract. Okay, if we see the distended urinary bladder, distended UB plus urethra. This is a micturating cystourethrogram. Cystourethrogram. If we see only urethra, this is retrograde urethrogram. This is retrograde urethrogram. Retrograde urethrogram. And then there are parts of the urethra, that is the penile urethra, then we have the bulbar urethra, the membranous urethra, and the prostatic urethra. Here what we can see, there is a stricture in the bulbar urethra. Stricture in the bulbar urethra. Bulbar urethra. Here we can see there is an extravasation of the contrast over here. There is a history of the straddle manhole or the bicycle injury. There is injury to the bulbar urethra. Bulbar urethral injury. Bulbar urethral injury. There is a blunt trauma. There is a pelvic fracture. If we see the pelvic fracture and there is an extravasation of the contrast, there is membranous urethral injury. Membranous urethral injury. Membranous urethral injury is present. Okay. And what is the investigation? This is the MCU study and this is the ultrasound. And what do we see? We see that the posterior urethra is dilated and there is a valve-like structure. The posterior urethra is dilated and there is a valve-like structure. This is indicative of the posterior urethral valve. This is indicative of the posterior urethral valve. Posterior urethral valve, and this abnormality, this sign is called as the keyhole appearance. Keyhole appearance. This is called as the keyhole appearance. And here the examiner has committed that these are MCU images. And what do we see? We see in MCU study we are seeing the contrast in the abnormal contrast in ureter and PCS. Ureter and PCS. This is indicative of the vesico-ureteric reflux. This is indicative of vesico-ureteric reflux. This is indicative of the vesico-ureteric reflux. Here the bladder is elongated. This is a Christmas tree bladder seen with the neurogenic bladder. Christmas tree appearance, neurogenic bladder. Bladder, and this appearance is called as the Christmas tree appearance. Here the bladder is appearing like a pear. This is a pear-shaped bladder. Pelvic hematoma. Pear-shaped urinary bladder. This is a feature of pelvic hematoma. Anything which is compressing onto the urinary bladder. It can be because of the lymphadenopathy. If it is in the settings of the trauma, it is a pelvic hematoma. If it is in the setting of a chronic condition, it is a lymphadenopathy. We see a calcified mass, postmenopausal female, and there is a calcified mass. This is a calcified fibroid. This is a calcified fibroid. Calcified fibroid. Here we are seeing the spillage of the contrast through the fimbrial end of the fallopian tubes. We see the endometrial cavity. We see the caliber of the fallopian tubes. And this investigation is called as the HSG investigation, hysterosalpingogram. Hysterosalpingogram. They can ask you about this investigation. They can also ask about this cannula. This cannula. This cannula is called as the Leach-Wilkinson cannula. Leach-Wilkinson cannula. Leach-Wilkinson cannula. This is an unicornuate uterus. Unicornuate unicollis uterus. Unicornuate uterus. Here the angle between the cornua is broad. This is a bicornuate uterus. Has a broad angle. has an obtuse angle. Here the angle is narrow. This is an acute angle, acute or narrow angle, narrow intercornual angle. This is a feature of septate uterus. This is a feature of septate uterus. This is a feature of septate uterus. Normal transabdominal sonography. This is a normal transabdominal sonography. And here what do we see? The endometrial cavity is distended by multiple small cysts. This is called as the snowstorm appearance. Snowstorm appearance. This is called as the snowstorm appearance. This is a feature of complete hydatidiform mole. Complete hydatidiform mole. The patient is receiving treatment for infertility. And then there are enlarged follicles. There is an acute pain abdomen. There is an acute pain abdomen. This condition is called as the ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. If there is a young female with infertility and this multiple small follicles in the periphery, this is called as the necklace appearance. This is indicative of the polycystic ovarian syndrome, PCOS, polycystic ovarian syndrome. Vertebral shapes are also important as the skull shapes. Okay, so here what do we have? We have a vertebra which is enlarged. This is appearing like a picture frame. Here the entire vertebra is white. This is called as the ivory vertebra. Ivory vertebra. Both of this is seen with the Paget's disease. And what type of skull do we have in Paget's disease? We have a cotton wool skull, seen with the Paget's disease. Here the vertebra is collapsed. Collapsed vertebra with normal IV disc space. Collapsed vertebra plus normal IV disc space. This is a feature of eosinophilic granuloma or Langerhans histiocytosis. Normal IV disc space. This is a feature of eosinophilic granuloma. Philic granuloma or Langerhans histiocytosis or Langerhans histiocytosis. Langerhans histiocytosis. Alternate white and dark areas are seen. Alternate white and dark areas are seen in the vertebrae. This is called as the Rugger-Jersey spine. This is called as the Rugger-Jersey spine. This is the X-ray. This is the CT. Rugger-Jersey spine. This appears like the jersey of the rugby player. Rugger-Jersey spine is a feature of renal osteodystrophy. Renal osteodystrophy. Renal osteodystrophy. Here we see vertical striations. Vertical striations are seen, and this is the axial CT. This is the axial CT, and it appears like the dots. It appears like the dots, and these dots are called as the polka dots. These are called as polka dots. This is called as the corduroy appearance. Corduroy appearance. Corduroy appearance. And both of this is a feature seen with the vertebral hemangioma. Vertebral hemangioma. Vertebral hemangioma. Vertebral hemangioma. This is seen with the lateral X-ray. This is the lateral X-ray or CT, sagittal CT, and this is seen with the axial CT. This is seen with the axial CT. If there is a tumor in the epiphysis, we see whether the growth plate is fused or not. If the growth plate is not fused, growth plate not fused, this is the tumor that we are seeing. This is a chondroblastoma. This is a chondroblastoma. And if the growth plate is fused, the growth plate is fused, this is a giant cell tumor. This is a GCT or osteoclastoma. 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 Tumor in the radius, lower end of radius. This is the classical site for the giant cell tumor. This is the classical site for the giant cell tumor. Metaphyseal lesions, if the bone is not expanded, non-expanded bone, this is a simple bone cyst. Simple bone cyst. This is a simple bone cyst. If the bone is expanded bone, this is an aneurysmal bone cyst. Expanded bone, this is an aneurysmal bone cyst. Aneurysmal bone cyst. And then we have two malignant tumors, spiculated periosteal reaction and a Codman's triangle. Sun ray periosteal reaction. Sun ray periosteal reaction. There is a Codman's triangle. Codman triangle. There is a spiculated periosteal reaction. This is an osteosarcoma. Osteosarcoma. Here what do we have? We have lamellated periosteal reaction. Lamellated periosteal reaction. Periosteal reaction. This is also called as onion peel appearance. Onion peel appearance. This is a feature of Ewing's sarcoma. This is a feature of Ewing's sarcoma. Okay. This is a diaphyseal tumor. This is a tumor that happens in the diaphysis. Osteosarcoma happens in the metaphysis. Osteosarcoma happens in the metaphysis. Chronic pain and deformity, multiple lesions. There are multiple lesions in the hands. This is enchondromas. These are enchondromas. Enchondromas. This is the Shepherd crook deformity. Seen with the fibrous dysplasia. It is seen with the fibrous dysplasia. This is seen with the fibrous dysplasia. What do we have here? We have a cortical continuity and there is a continuity with the medullary cavity. This is an osteochondroma. osteochondroma. This is an osteochondroma. Okay. Radiotherapy, we all know, it is treatment with radiation. It is the treatment with the radiation, and we have different forms of the radiotherapy. Teletherapy, it is done at a distance. Then we have the brachytherapy. The radiation source is close to the tumor. And then we have the systemic radiotherapy, iodine 131, that is used for the thyroid cancer. And then we have the phosphorus 32 for the polycythemia vera. Polycythemia vera. What are the different forms of the teletherapy? Okay, external beam radiotherapy. This is nothing but the teletherapy. Teletherapy can be done with the cobalt 60 that uses the gamma rays, or it can be done with the X-rays which uses the LINAC. LINAC stands for linear accelerator. Linear accelerator. It is a type of the X-ray tube. If we use with anode, it is with anode, what is produced? X-ray beam is produced. X-ray beam will be produced. And if we use without anode, which beam will be produced? It will produce an electron beam. Low energy electron beam is produced. Electron beam is produced. This is used for the treatment of the superficial tumors like the cutaneous T-cell lymphoma, that is called as the mycosis fungoides, or it is used for the intraoperative radiotherapy. Proton beam therapy, it produces the Bragg's peak. It is the most advanced form of the teletherapy. Fractionation is another concept that we need to understand. Fractionation is nothing, it is the dose. It is the dose of the radiotherapy. So normal fractionation or the regular fractionation is 5 doses in a week, once daily from Monday to Friday, and then Saturday, Sunday is off the dose. The patient is not exposed to the radiation. Then we have the hyperfractionated radiotherapy. Hyperfractionated, more than 5 doses are given per week. That means more than once a dose is given in a day, BID or TID. It is used for the aggressive gliomas and the small cell cancers. Hypofractionated is less than 5 fractions per week. It is used for the palliative to reduce the pain in the bone metastasis. Chart is the continuous hyperfractionated. Without the gap, hyperfractionated means more than once a dose is given in a day, and then accelerated in a short duration of time. This is used for the non-small cell lung cancer. So the fractionation is related to the dosing of the radiotherapy. Normal is once daily for 5 days, Monday to Friday, and Saturday, Sunday is off. Hyperfractionated, more than once daily, and that is given for the aggressive tumors. Hypofractionated, less than once daily. It is used for the palliative radiotherapy. Okay. Brachytherapy, intraluminal, is for the esophageal cancer. Intracavity is for the pelvic tumors, most commonly for the cancer cervix. Interstitial is for the prostate cancer. And molds is in form of the molds. It is kept over the superficial tumors of the head and neck, for the ocular tumors, for the penile cancers. Ocular and then penile cancers. Radiosensitivity of the tumor also. These are the tables that you need to revise just before the exam. G2M is the most sensitive, S is the least sensitive. Organs we already know, ovary and testes. Vagina, bone and CNS is least. Bone marrow, undifferentiated dividing cells are radiosensitive, mature cells, quiescent cells are not, and then lymphocyte is radiosensitive, platelet is not radiosensitive. Okay, so these are few of the important topics that you must revise before your exam. Also remember the nuclear scan tables, they are very important. The half-life tables, they are all important and you need to revise before the exam. Remember that the common things are more commonly asked in the exam. Revise your notes, okay, and practice the questions. Time management is also important because now you are going to give 6 sets of paper. It is not just 2 sets of paper, you are going to appear for the 6 sets of paper. So appear for the grand test, try to revise whatever the content is not important. It is important you should read the content which you can revise. Okay, so thank you all and best wishes for your exams, and do share your feedbacks, and I'll share this in the with the admin group, and they'll post it on the app. Okay, so thank you so much and best of luck for your exams. God bless you all.